you very much again. And now everybody is waiting for Dr. Catherine.
I'll share my screen. Is that
Yeah,
okay?
just one moment. Yeah. As I mentioned at the start of the meeting,
Sorry.
Dr. Catherine is from Ireland, and she's looking about the National Committee of the Organ Donation, and she is working in the Limerick Hospital, and she is going to talk about the effect of COVID-19 and how did it affect the organ donation. Welcome, Dr. Catherine.
Thank you, my dear. Now I must get my screen. Can you see my screen? For some reason, I start at the end.
Now,
okay, is it visible now? Yes?
Yes.
Yeah.
Okay, so Sad, thank you very much for inviting me, and this is my first time to attend this conference, and it's been a wonderful faculty, and thank you to all the other speakers. So Sad asked me to talk about organ donation and the pandemic and COVID, and initially I thought about it, and I said I think somewhat about the ethical issues that we faced, those of us actually in medicine, in terms of the COVID-19 pandemic, and in particular in relation to organ donation. This is a nice publication by a group from Canada, where they looked at their ethical principles and how, and what they actually do in relation to organ donation, that referred to self-sufficiency organs, population-based ideas, accountability, fairness, security. And they looked at the ethical issues and essentially the challenges that was reported by various donation organizations around the country and how it challenged them. They looked at the challenges in relation to consent for organ donation, tissue donation, because we often didn't let families into hospitals around the world. And they looked at the ethical issues identified for allocating organs and tissues during the COVID-19 pandemic. And I don't intend to go into the article in its completeness, but they did summarize nicely what worried us: the risk of COVID-19 transmission to our transplant recipients, either in the hospital or after receipt from the donor, particularly when they're immunosuppressed. And at the very beginning of the pandemic, there was very significant morbidity in our transplant population from COVID-19. There was also the risk of COVID-19 exposure to our healthcare professionals providing transplantation services, and we could potentially ourselves then proceed to infect our patients. There were issues in relation to the wait list mortality. When you actually, if you don't give someone a kidney, they keep having to come into hospital to get, to get their dialysis, and that exposes them to the risk of getting COVID within the hospital. So it isn't really a black and white issue. In terms of the informed consent of a recipient receiving a new organ in the presence of the pandemic at the very beginning, particularly in terms of the risk of immunosuppression, you couldn't give them as much information as you normally would. And obviously there were ethical issues, certainly in relation to organ allocation, and that became very acute in some countries after the vaccines became available, when some recipients didn't wish to receive a vaccine and felt their position on the waiting list might be jeopardized because of that position. So there were the ethical things we faced, and this is a study I found in the Lancet, and they looked at a number of countries, about 22 of them around the and they looked at what actually happened in various countries and what happened. And essentially, this is a screen, but I'm going to skip for the interest of time. And they thought three patterns. There was a sharp decrease in transplant activities, despite a low number of deaths in places like Argentina, Japan, and Chile. There was a decrease in sort of parallel with the incidence of deaths in Norway, Germany, Canada, and Portugal. And then there were other countries, such as the United States and Italy, where in fact, they had a very high number of COVID-related deaths, but they didn't seem to have as significant an effect on their transplant activity. And that's the same slide. And what they did have in this, and I hope this you can see this, there was a little link to a website that I went to, where in fact you could see at the very beginning of the pandemic, there was an immense drop in transplant activity around the world, and that happened everywhere. And that included many, particularly kidney transplant programs, halting both their living and their deceased programs, because those patients at least had the dialysis option. Now, we didn't in Ireland halt our other programs, but we did halt our kidney transplant program for Pine. And this is 2020. You can see that the activity falls begins to return somewhat in the summer months, or certainly in the summer months of the Northern Hemisphere, and then fell again as we faced what I would call the alpha wave in Europe. And this is another slide where, in fact, they related the COVID deaths per million and the overall diminution of transplantation. And you can see they had Ireland in it there. And we had a very significant reduction in our transplant activity in Ireland, despite having a very low excess mortality from COVID-19. And the thing that bothered me about that study, and I think it was an interesting study, is what they didn't look at was the ICU bed capacity of the various countries that were affected. And because I live in Ireland, I'm particularly upset about this figure. We're at the very bottom, I hope you can see that, of the ODIC, but we have very few ICU beds per head of population. Whereas countries like Germany and the United States did very well in terms of transplantation throughout the COVID-19 pandemic, despite having significant excess mortality. But they had a lot of ICU beds. And we had a significant problem in Ireland, as they did in other places. And we all saw a reduction in our transplant activity for some fairly significant and good reasons. And these are figures from the Council of Europe and the ONT, who regularly give figures for us in Europe. And the reason why there's a green bar there is these were produced for us in the Irish organ donation and transplant community. We had, in the first year of the pandemic, an almost 1/3 reduction in our activity with a slight recovery in 2021. You can see here for specific organs, our kidney transplant program probably did slightly better because they managed to re-energize their living donor program once the first few months were over, which obviously ceased depending on viral transmission in the community. But you can see everywhere there is a reduction in activity, except with some exceptions. I think Denmark had an increase in one, and there were significant differences. And Marty's already showed you these. And our liver transplant program took a huge hit, as did our lung transplant program, as did many lung transplant programs, with the exception, I think, of perhaps Austria, who is a leader in Europe in terms of lung transplantation. And then heart transplantations in Ireland were very much affected, but we have a very, very small population, and we don't have a huge number of patients on our heart transplant list. And there is no doubt that the COVID-19 pandemic created a lot more anxiety once we got used to it about the thoracic organs than it did about the abdominal organs. And these are figures from Ireland. These are our summary figures for the last 5 years. So our total number of transplants in 2016 were quite low. We got up to 260 in 2017, and our average is about 230 to 250 a year in terms of transplants. But obviously you can see here in the first year of the pandemic, we had only 162 transplants with 63 deceased donors. Last year we had 65 donors. I'm going to go back to that slide. With 25 living donors, and we had 206 transplants. So our numbers are beginning to recover, but we have a way to go. One of the things that interested me, and Marty slightly made reference to this, these are the figures in ICU in Ireland, and these are our COVID patients, the pink line. And for every surge in viral transmission we had a very dramatic presentation to our ICUs of our other patients that needed intensive care units. Obviously, with very long lockdowns, people didn't have road traffic accidents, but there was a significant reduction in the admission of things like strokes, out of hospital cardiac arrests. And this wasn't because they weren't referred to us, it's because they didn't come. And I think there was something about the way we lived during that period of time, which was very significant, that actually diminished the number of potential donors that we were seeing. And obviously we had a very significant reduction in our conversion rates. So donors might have been offered at the very beginning in Ireland, but they were for thoracic organs for people at high risk, and we weren't doing kidneys for about 3 months of that period of time. And this, I think, significantly reflected the fact that we had a very big problem in Ireland with a very low ICU bed numbers, even though we did expand our ICU capacity for the pandemic in a surge manner. But what is the future? I mean, COVID-19 is never going to go away. It's now something that we are going to live with. And thanks be to God, we've had successful vaccination, and large numbers of countries are achieving very high vaccination rates. And this is from Cleveland, where they actually published their success in transplanting kidneys from donors with new SARS positivity. And essentially, they highlight what a lot of us are now beginning to realize, that if you're higher risk as a donor to your recipient, obviously, if you are diagnosed early, if you have active COVID infection, if you have significant signs on your chest x-ray that you may be well, and if you have CT values in your PCR test that are below 30 in Ireland, and in this instance they use 10, and if your COVID exposure is relatively new. But they have realized as they've gone on, and I think and hope we will get more data on this from the worldwide organ donation community, that if you go beyond 28, maybe even 10 days, if your CT value is low and you're asymptomatic, there is potentially a way for you, if you wanted to be a donor, to become a donor. And there is a way, particularly for abdominal organs, for you to potentially receive a transplant for these patients, provided you're appropriately given information and give appropriate consent. Now, I couldn't get the figures from this, but they found this online, and this is from our Italian colleagues. And they had 30 transplants conducted by their teams from donors with past resolved COVID-19, but they had a further 38 in 2021 who had active COVID-19 infection at the time of their death. And initially they realized that they were going to have to do something, and they needed people who'd had COVID to have 2 negative PCR tests for a period of time apart with a negative BAL, although we don't use BALs in Ireland, we use sputum, before organ commitment could be considered. And they had successful outcomes, which they presented at a meeting, and I haven't seen the publication. And then in the end of 2020, they'd realized that perhaps we could look at donors with active infection, but only if they were asymptomatic. And obviously as well, they, and I would agree with them, stipulated that the recipients for those organs should be triple vaccinated with the mRNA vaccines, that Pfizer or Moderna. And this is NHSBT, and this is information that I'm publishing that's actually on their website. They initially felt that current infection would mean that you couldn't donate. But in the same document, they acknowledged that there's growing experience in the US and Europe, that transplanting organs from selected donors in particular circumstances that are positive for COVID-19 may actually be possible. And in fact, it's very hard to read this, but I've recently been involved in referring a case to them because we share organs with the United Kingdom quite frequently. And there is no doubt that if you have a positive test and you're asymptomatic, you will be considered with a lot of workup as a potential donor in the United Kingdom. I don't know how many they've done, but they do consider it. They didn't accept our donor in that particular circumstances because the CT value was too low, even though I feel it was an Omicron variant. And the ODTI, who are the national organization in Ireland that actually are the procurement group, and they are one of the responsible bodies for organ donation and transplantation in Ireland, have obviously an agreement, like all other countries, that you do nasopharyngeal and endotracheal aspirates for COVID-19 before donation. But we would potentially consider patients if they are 10 days after previous infection. And the things that we would consider are the recipient vaccination status, if the donor had prior infection, and whether or not antiviral therapy was required. However, this is a draft document and it hasn't yet been agreed. You'll notice that in any circumstances at the moment in Ireland, if your COVID-19 is positive, you are not currently offered as a donor. And that's something that we're going to work on. Our colleagues in Spain, similarly, if you have a history of COVID-19, if you end up, if you're greater than 19 days since the initiation of symptoms, greater than 72 hours of symptoms, if that's not the case, they will look at you as potentially as a non-standard risk donor. If you're dying of COVID-19 as a cause of death, the donation doesn't necessarily proceed. But if you are PCR positive and you're an asymptomatic carrier, as my last potential donor was, then they may consider you as a non-standard risk donor for selected recipients with specific informed consent, and also the outcomes, which I think hopefully are going to be reported internationally for those of us So we know what to do with these people, because it would be really good for the recipients if they could get organs. But also, and this is my ethical guidelines, it's not a Canadian one, I have a responsibility to the donor who is my patient and to the donor family to do what they wanted them to do, if it is at all possible. I have a responsibility to the staff in my intensive care unit so that we can continue to offer organ donation at the end of life, because this would be a standard of care that we aspire to in our country. I have a responsibility to the transplant recipients who hopefully could potentially receive life-saving organs, and also to the transplant teams whose raison d'etre, in fact, is to actually perform transplantations. And essentially, I have a responsibility to society, and we all do, to ensure that as many organs as we can are offered for donation in this new era. And I'm going to finish my talk, and hopefully I haven't gone too much over time, with a few Irish sayings. And these are ones I've used a lot in the last 2 years, because we've had a very difficult last 2 years, and there aren't literal translations for them in English. But the first one is Er Sca Chéile Maria Nadina. And that means, literally translated, we live in each other's shadows and we depend on each other. And even after death, people can contribute hugely to the lives of other people. The other one we've been using a lot in Ireland is Ní Nart Go Cur Le Chéile, which means that there is no strength without unity. And that's been a very huge and significant part of our societal response to COVID-19 that has led to one of the lowest excess mortalities thus far from the pandemic in Europe. And the third one is one that I quoted to my daughter, who, being young and keen to get out and about during the lockdowns, I said, the Ada an lá tagan an trona. So no matter how long the day, the evening will come, which means this too will pass. And the last one is very important. It's a saying we use in funerals in Ireland. It's a yeshte gareva anamika diulish. And it's essentially a way that we have of saying something honored about the people who've gone before us. In particular, this is for our donors. And it says, literally translated, means that they may stand at the right-hand side of God. And essentially, that is my talk. COVID-19 has been a challenge. It has reduced donation rates, particularly across Europe. It has had less effects in other jurisdictions, and I do think we need to look and understand more about that. I think some of it has got to do with different death rates. Our country has one of the lowest death rates in Europe, but that said, our organ donation rates were hit very badly, and I think that reflected a difficulty we had, both in terms of our capacity in ICU potentially, but also in terms of the fact that our lockdowns were long and tedious and our donors didn't actually present. And that is my talk. Yasser, are we still there?
Thank you so much, Dr. Catherine. Actually, COVID affects our all medical and clinical practice, including, of course, organ donation. And now we have 10 minutes for open discussion. If any comment from any speaker, from Saad, from discussion from our attendants, maybe start with Dr. Marty. What do you think about the meeting in general? Can you add some?
Well, I think that first you have with mega meeting, you engage a lot of people, and it is a continuous education that you regularly do. But I think was necessary this one, because you start first to fix what is the brain death and make the diagnosis with Professor Doyle and Jose Maria Dominguez. And also I liked the presentation from India. The difficulty is absolutely different, the practice, and probably in the Middle East we have the same issue. People is not aware about this diagnosis, not motivated, is afraid, there's lots of training, and that means that they don't transmit to the families probably this security or this commitment. No, I think is one. No. Second, the COVID, as Catherine said, have affected all of us, but we have learned a lot. Paolo Grossi from Italy said, no, you can use also patients who have been COVID. Or if the recipients are vaccinated or having the previous COVID, then even in Emirates, we use one donor, thanks to Paolo Grossi, who advised us. No? And for the future, my topic, I think that the DCD could be a complementary source for many developing countries, But for many donors are in the emergency area and are in the streets. And my idea that in 10 years or in 20 years will be a few brain death or few will grow out as a donor, and this will be the main source. My medical director was Josep Brugada, a cardiologist from the Brugada syndrome. And Marty, don't look more for young trauma that doesn't exist. Look for the ischemic cardiopathy as a potential source. But in many countries, it's not allowed, it's not regulated. And the meeting, yes, sir. Thank you for the invitation. Thank you, Catherine, for your nice words about the Spain and the DTI and so on. And we are happy with my colleague, Jose Maria Dominguez, also to be here with all of you. And Dr. Tarek, you explained the donor maintenance perfectly, but we need that this knowledge is transmitting any donor to have a good organs and a good outcome, okay? Thank you, and Dr. Satmar, thank you.
For Professor John Doyle and Tarek, Professor John Doyle mentions religious regarding from Islamic countries or Jews or Christian, and he mentioned that some Islamic countries are still conservative. Tarek is working in Saudi Arabia, and they have, I think, very wide experience in that. So can you give any comment, Tarek, about the current situation of the Islamic countries?
Well, it differs from one country to another. So in Saudi Arabia, there's a fatwa recognizing brain death, and it is well recognized, and it is considered once the patient is certified to be brain dead, this is death, clinical death. And we have a very active programs for heart transplant, and there's no problem with that. Although we sometimes, again, face problems with the families, they insist on doing everything. The culture of organ donation is still not widespread. We need to do, the public should be more aware about this. My home country in Egypt, as you know, we only do living related donations for a lot of issues, legal and as well as the religious causes. Because to prevent exploitation of donors and medical legal problems.
Tarek, we have a question here, please. In Saudi Arabia, do you do clinical tests only, or you do any radiological tests like carotid artery or something like that?
Pardon me?
In Saudi Arabia, do you do clinical tests only, or you add some radiological tests like carotid or cerebral artery perfusion or something like that?
Not in all cases. Ancillary tests like EEG is done and the apnea test, but a few cases they do also other more advanced cases like cerebral angiography and.
Okay, we come now to the Professor John Doyle. You hear the two speakers from Spain and you are in the United States. And as you know, Spain is the top country in the organ donation. So can you give some short experience about United States comparing with Spain?
Well, one of the big differences is that in the United States, you are not automatically a donor unless you sign up in advance, whereas in a number of countries, including Spain, you are automatically a donor unless you particularly opt out, which you can do. So that's a big difference, and that will influence in a strong way the availability of donors. I would recommend that most countries go to a process of automatic donation unless they have a contrary objection. But that is difficult to do. And kudos to Spain for having been able to accomplish that. My hope is that other countries will follow suit. So that's the big difference.
All right, yeah. Dr. Jose Maria, any comment from your side?
No, I think that the session of today have been very rich in concepts, in definition, even in disagreement. And I think that it is very important, because the only way to improve the donation is that all the people feel comfortable with the diagnosis of brain death and with brain death concept. No? So sessions like today, I think, are very important in order to try to improve the comfortability of health professionals with brain death, and consequently that will improve the donation.
All right. Okay.
I have
Dr.
a
Catherine,
question to Professor Marty
okay.
this
Okay,
time.
Tara, go ahead. Yeah.
Okay, so Professor Marty, in the era of ECPR and the use of ECMO for after cardiac arrest, uh, how does this go hand in hand with your technique for harvesting patients with after cardiac arrest? So how common is ECPR in Spain?
Yes,
When do you decide whether to do
yes,
ECPR and whether to decide to declare
yes.
patient dead? And
Yeah, we are a developed country, but not much resources in health, and ECPR is very incipient. It only started in the last years, no. But I have to tell you that have been in my hospital in this year 2 cases of ECPR. So Barcelona is a 2 million city. We have only 1 ambulance who have the ECPR possibilities, and they take the patients with a cardiac arrest. They do CPR starting in the ambulance, but some of these patients, one had been in the hospital, and after the resuscitation of the heart had been also an oxygen in the brain had been not recuperated, and finally it had been decided as a control DCD donors. It's not often because our another extra issue that happened for me also is to utilize the organ donation from euthanasia. So, I think for 10 years or 15 years, only was Holland and Belgium who have done few cases. In Spain, the law of euthanasia passed in the last year in the parliament, have been approved, and now maybe some cases who wants to combine the wish of dying, no, plus the wish of donation. And because of our previous experience in DCD, that's been very useful because we can help them to die, is what they wish. But second, also you have the opportunity to do that. In one case from ataxia guy, very younger, we use the pancreas, the liver, the heart, the lungs, all the organs. But let me make a comment general. It's not because of the law in Spain that we have more donors, because the law said it's automatic. You are considered a donor. But ethically, doctors, physicians, ethically is to inform the family about the procedure, about the wishes. And I tell you that Spain we have 14% of family refusals because we request any family before retrieval about the decision in life. We don't have a resist, but we respect the family. And the key point is that you, the anesthesiologists, are the one driving donations. So Jose Maria Dominguez the Star, I don't tell the years because we are some experience. Many years ago, being the transplant procurement manager in Seville, I started to be the transplant procurement manager in Barcelona. So there is like 300 doctors in Spain is 47 millions that part-time or full-time, only a few, are dedicated to the organ donation. And that helps all the procedure to understand the evolution of the patient, the diagnosis of death, the result of the treatment, the advice to the family, the donor maintenance. So donation is derived by the ICU and anesthesiologist people, not by the transplant teams. Like a kingdom, in the ICU, we are the queens. The king is the surgeon, we know, no? But we don't care about surgeons, the anesthesiologists, but the kings are in the ICU and the donors are in the ICU and in the emergency area. And said Dr. Tarek, the donors are outside of the hospital with the ECPR, with any maneuver, any ischemic cardiopathy outside of your hospital in Saudi is a potential donor. Why? Because this kidney with 30 minutes ischemia or whatever, is nothing. It will be a cutubo necrosis after resuscitation, but we can do this body normothermic regional perfusion. We can check the viability of the kidney in the machine today. Even today is a better kidney than the one who is a expanded donor criteria, 70 years old, cerebrovascular accident, hypertension, diabetes, 10 days in the ICU, and whatever. This is a worse kidney. This is all for all. For the younger people, DCD, who are in average are 45 years old, these people are the kidney of election, and the survival after 10 years, as I show for my friends in the nephrology department, they follow very well. No? We are happy to be with you, Yasser and Catherine.
Yeah.
Thank you. Thank you.
Maybe last comment from my side. I asking Dr. Catherine, you hear the samples sounds from India, from United States, from Spain, and you have long experience in Ireland. Do you think after hearing all that, you can do something more in Ireland regarding organ donation?
Well, what we need in Ireland is to expand our organ donation personnel in all of our hospitals. And we will do that. And and also possibly look at our conversion rates. And also we plan to have a national audit of all deaths in ICU and all deaths in A&E to see if we miss any donors. My theory is you have to offer the option to all appropriate donors first, and we have to know that we're doing that and we have to see what's doing well. So we plan all of that in the next year or two. And in relation to the brain death question, a guy called Sam Shemy, who's a Canadian, I think, has led a particularly nice project called the Worldwide Brain Death Project. And he published worldwide sort of summaries of all of the ways and means of actually diagnosing brain death. And that does include in it the issues about ECMO and how you diagnose brain death on ECMO. It's a very nice document. I think it would have been published maybe 5 years ago. Thereabouts. And I do actually agree with our colleague from India. I actually think a worldwide series of tests. Now, they're all similar, but there's all subtle little differences. So I think that would be good. We don't generally have a problem in Ireland about the concept of neurological brain death with our families. Sometimes, yes, but it's a very well accepted cultural concept in our country. And theirs is a very... So we don't really have that problem, but we do occasionally have a problem with families, but generally we give them time and they take it. But I mean, my thing about donation, and it's wonderful for the recipients, but for the families who lose their relatives in generally tragic circumstances, donation is really good for them. And it's something that I aim to give them if at all possible. And there's a great side effect in that lots of recipients get organs and do well.
Yeah.
Thank you for the talk. Thank you. It was beautiful, lovely evening.
Okay, Saad, thank you everybody. Saad will.
Thank you. You can close the. You can go ahead and close the session. Yeah, thank you so much. Thank you.
Yeah.
Thank you everybody.
Thank you much. Thank you much for this.
Thank you.
Thank you.
Thank you, everybody.
Really nice,
That was great.
really nice.
That was
Thank
great.
you. Thank you.
Thank you to all the
Thank you all.
speakers and the
Thank you all.
moderators.
Thank you.
Hi, everyone.
See you in Emirates, Yasser. See you.
Hi,
See
so,
you.
yeah,
See you
thank you.
soon.
Thank you very much.
I've got
Yeah.
a question,
Have a nice evening.
Professor John Doyle, please. Is there time for it?
I'm here.
First of all, thanks for your outstanding presentation. I was once attending a meeting in World Health Organization in Switzerland, and they said that it's a crime to have a patient with entire brain death and not to put him on supportive therapy and mechanical ventilation. This money could be spent on another patient to save lives. In the meantime, you're offering the relatives of the patient hope that their patient might recover and he'll recover. Apart from this, the ancillary tests and the transcranial Doppler, they are not present in the low-income countries. So how can you confirm the entire brain death in such countries? What's your opinion?
Well, the answer is in most countries, including the United States, death of the entire brain is determined entirely by clinical evaluation. And ancillary tests are only required where there's ambiguity, or in the pediatric population where there's always ambiguity. in select cases. So the question is it squandering resources for one to keep a brain dead person on extracorporeal membrane oxygenation or ventilation with inotropic support for extended periods? And there's controversy on this. And I gave two examples in my talk where some people would say we have to be tolerant of other religions and other viewpoints, and others who say yes, but we can't squander resources that should be made available to the population at large. So there's no answer to this. There's just opinions on it. But I do hate to see resources squandered unnecessarily and false hope provided to families.
Well, thank you very much for that. Thanks a lot.
Okay. Okay, it was a pleasure. Thank you very much. I'm going to close out.